Thank you, one and all. So I'll jump into this topic. So the way I'll divide this topic is the first half, first 10 minutes, I'll talk about the technical aspects of this high flow nasal oxygen therapy. I'm sure many of the listeners would have already used this, and there was a lot of expertise that was gained during the COVID time. And the second part, I will talk about all the evidence. So I was quite bewildered to see the amount of evidence that is generated since the first paper that came out in around 2015 about the benefit of this particular equipment. So today I won't be talking about its evidence or role in COVID per se, but I'll talk about general ICU conditions, predominantly respiratory failure. So when we look at HFNC and compared to the nasal cannula, there are certain distinct advantages. As the name sounds, high flow. So it's a high flow oxygen device. And compared to the other conventional, so it is documented to increase the functional residual capacity by about 25% with the use of HFNC as compared to the conventional oxygen therapies and reduces the dead space. So I'm sure most of the listeners would have seen this equipment stationed in their ICU. So it has various components to it. So one of them is the gas source, and one of them you have this pressure relief valve, and you have a humidifier. I think that is the key aspect which humidifies the oxygen. And then you have a nasal interface. It's not like an NIV, it just sits into as a nasal cannula. And that is a distinctive advantage where you do not have issue with compliance or claustrophobia. So just breaking down the things, you have a flow meter, which is very unique to this device because it generates high flow rates, even up to 60 liters per minute. So that's why you have these flow meters, which are customized to this high flow device. And that is something one needs to bear in mind. And the flow is equated to the titratable FiO2. And generally those charts are given along with this. So you can refer whenever we are using this as to at what flow, what sort of an FiO2 is delivered. Then you have an air oxygen blender, you have a sterile water for humidification. Then we have a heated breathing circuit and nasal cannula and active humidifier and heater. So the flow settings are fairly simple. So there is an autofill water chamber, then there is an oxygen inlet and integrated blender and analyzer. As I said, the flow that gets generated is anywhere from 20 to 60 liters. So at about 60 liters flow rates, you can deliver up to 100% of the FiO2 that may be needed for severe hypoxemic respiratory failure. And then these equipments have inbuilt temperature sensor. So the whole advantage of high flow nasal cannula is it sits like a nasal cannula. So the ease of administering, the compliance, comfort, and we do not have issues with the pressure effects of these devices, unlike some of the NIV device where you may have claustrophobia, compliance issue, and patients getting to keep it, and the pressure source, and so on and so forth. So that aspect is something that is negated with this HFNO. So there are few additional benefits that one gets when HFNC is being utilized as compared to conventional oxygen. So during inspiration, there is some amount of a PEEP that is generated during the inspiratory process. And it is a flow dependent breaths, and there is some amount of pressure that is generated. And it does promote slow and deep breathing. And it is shown to improve the alveolar ventilation during the inspiratory phase. And during the expiratory phase, it has, because it generates a bit of a PEEP, it has ability to clear the secretions well. So it is effective in clearing upper airway secretions. And it does reduce the rebreathing of gas within the with high CO2 within the oral cavity. So that is another distinct advantage during the expiratory phase. And it is shown to reduce the dead space ventilation as well. So in the expiratory phase. So these are some of the advantages that it has. So a bit of a pressure generated and effective in clearance of mucous secretions, prevention of rebreathing, improving alveolar ventilation, reducing dead space. So these are some of the additional benefits that it confers when compared to conventional oxygen therapy. And as I said, the humidification is another distinct advantage because it has a water heated humidifier. So the air that is breathed is humidified effectively. And most listeners would be well versed in how important is humidification because humidification is very much needed for good mucociliary clearance of secretions, which is often an issue to cause sequestration of the whole mucus secretion. So humidification helps in clearing of these secretions and prevents sequestration of these. and it helps in good mucus clearance. So this is also some of the advantages with HFNO, which possibly we won't have in conventional oxygen therapy. And it is an open system. Like in NIV, we need to put a lot of energy and emphasis on a good mask seal, isn't it? So that possibly is not needed because it's an open system and there is no seal that is needed, and it snugly fits into the nose and it is very comfortable. It does not cause any pressure sores or excoriation or ulcerations in the nasal mucosa because of a good humidification and an open system and a good compliance, that is comfort. So these are some of the technical aspects of HFNO. It can be called a HFNOT, high flow nasal oxygen therapy, or high flow nasal cannula therapy. So it can be changed interchangeably. So comfort and tolerance is the key sort of a distinctive feature of these HFNOs. So there are certain criteria which has been accepted as possibly that we could agree upon that it can be used. So it has a reasonably good body of evidence in hypoxic respiratory failure. So as I said, I was quite bewildered to see the number of articles that have generated since 2015 in this area. So I'll take you through some of them. And there is a sort of conditional recommendation in patients following extubation where there is a risk of possible reintubation, where it has shown some benefit following extubation in certain group of patients where there may be a risk of ensuing respiratory failure and reintubation. And there is conditional recommendation in the post-operative respiratory failure or post-operative atelectasis, where the oxygen that would be needed may be much higher, and high HFNO can be looked at as one of the alternate for the other oxygen devices. And for the peri-intubation, like if for pre-oxygenation, this possibly is not applicable to our ICU setting. So as a pre-oxygenation strategy in OT, there are few studies that have come. So we won't touch today about this aspect. This is more of anesthetic perspective. So these are some of the recommendations that are based out of a lot of studies that have come out over last 10 years. Over a decade, there are huge body of evidence that has been accumulated in this HFNO. So when we look at evidence, as I said, I was very pleasantly surprised to see the number of articles that have come. So in fact, the one article which made a lot of news was in 2015, which we have discussed in our multiple forums, which was a Florale trial. So that came from the French group, and that really paved pathway to multiple other studies that came in after that in this area. And if you see in hypoxic respiratory failure itself, there are 14 randomized controlled trials that have been generated in HFNO. So there is mammoth amount of evidence that has been accumulated in this area. And there are 4 meta-analyses just in hypoxic respiratory. That's why possibly it gets a better sort of a substantiation. And in immunocompromised, there is 1 prospective study and there is 1 randomized controlled trial. And there are 2 post-hoc studies in immunocompromised. And post-extubation respiratory failure, there are 2 randomized controlled trials. And post-surgical respiratory failure, even there where one would believe there may not be too many, there are 9 randomized controlled trials and there are 2 meta-analyses. So this is the sort of body of evidence that is currently available. So obviously we won't go through each and every trials, but we look into what are the robust sort of the evidence that at this point of time we can look up to substantiate ourselves in using this HFNO. So we had to start this discussion with Florale trial because that was the study which came in 2015, which excited all our intensivists. I'm sure Himal and Sunil would agree in this forum that this was a study which was extensively discussed. This came from the French group in NEJM. It was called a RIVA network group that came in NEJM. So this particular study was done in non-hypercapnic hypoxemic respiratory failure. So they took only type 1 respiratory failure and they compared 3 strategies of therapy, HFNO versus what is conventional oxygen therapy and NIV. So they compared these 3 modalities and they took patients who had PaO2 by FiO2 less than 300. So, or at that point of time, it would have been called acute lung injury. They took these patients. So the primary outcome was to look at the day 28 intubation rate. So they basically saw that whether by using HFNO, they could reduce the intubation rates as compared to NIV. And the secondary outcome, they looked at all-cause mortality, ICU mortality, and day 90 mortality, and day 28 ventilator-free days. So these are some of the outcomes they looked at. When you look at the results, the primary outcome was to see if HFNO was successful in reducing the intubation rate. And this was, so 310 patients, 106 were in HFNO, 94 in conventional oxygen therapy, and NIV 110. As you see, the intubation rate, it failed to show any demonstrable benefit. So it did not achieve statistical significance. There was no difference in intubation rate. And but what it showed is day 28 ventilatory free days, which is a good indicator. That was higher in HFNO, which means it reduced the duration of ventilation or oxygen need in these patients. So that was a positive thing. But interestingly, what came out of this Florale study, which excited all of us, was the mortality. So they looked at 90-day hazard risk of death between the conventional oxygen therapy and HFNO, and they found the death was more in conventional oxygen therapy as compared to HFNO, that attained statistical significance. But this did not excite us because obviously HFNO, you're giving more oxygen, they might have done well as compared to conventional. But what excited all our intensive care group was its comparison with NIV, where 90-day hazard risk of death was found to be more in NIV as compared to HFNO, and that attained statistical. So this raised a lot of eyebrows amongst us as to, because until then we were only depending on NIV as a source once they failed on conventional oxygen. But here this study came telling that HFNO fared better than NIV in reducing the deaths. So that really excited. Obviously, when you dwelled into the study, there were a few other nitty-gritties that would have explained this. We will not dwell into that. But the conclusions they drew at the end of this was in non-hypercapnic hypoxemic respiratory failure, comparison between these three groups, although it did not show any difference in intubation rate, HFNO usage led to lower 90-day mortality. So this excited all of us. And then possibly this study paved the pathway for multiple studies that came after that. So we'll talk about the 4 key meta-analysis that came. So this is the one of the latest meta-analysis is this, which came from the US group. This is the largest meta-analysis. This came as late as 2021. So meta-analysis of 14 trials. They compared HFNC with the conventional oxygen therapy, and intubation rate was no different. And the escalation of respiratory support, they compared between HFNO and conventional. Again, there was no difference with regards to the need for escalation. So this was sort of a negative study. Basically, it's a meta-analysis taking all the 14 randomized controlled trials done in hypoxemic respiratory failure. We did not show that whether it really reduced the intubation rate. But what it showed is it improved the dyspnea for the patients. The subjective symptoms of dyspnea and comfort level was more, and one trial showed it did help in reducing the hospital-acquired pneumonia. So this was the previous year one, which came in 2020 by the Canadian group. This was a meta-analysis of 9 good quality trials they took. And this was a positive trial where they showed a positive study rather. Intubation rate was significantly reduced with HFNC. As you see, the confidence was significant. And the escalation of respiratory support also significantly reduced with the use of HFNC. And again, you see confidence intervals being significant. So this is another meta-analysis with a good, robust randomized control trials that was taken. And they found HFNO help in reducing the risk of intubation rate and reducing the need for escalation of respiratory. When you say escalation from HFNO, someone possibly getting worse, needing intubation, or possibly needing NIV, so on and so forth. And but mortality, length of stay, there was no difference between conventional oxygen therapy and HFNC. So this was another meta-analysis. I'm sure the listeners would know China has done a lot of meta-analysis. This came from the Chinese group. So this was meta-analysis of 6 trials. They looked at HFNO and conventional, and even in this study, intubation rate was significantly less with the use of HFNC. But the problem with this study was they used mix of patients. They did not take only hypoxemic respiratory failure. 2 studies took that. 3 studies took post-extubation. So 1 trial took broncho. So it was a mix of all these patients. So we cannot say this study was purely looking at hypoxemic respiratory failure, and that was the flaw. That's why I would call this study as a equivocal. But what they found in this study was when they compared with NIV, as Florale did, HFNC with NIV and HFNC with conventional oxygen therapy and the need for NIV, there was no difference. So even when comparison with NIV, there was no difference with HFNO, because the Florale trial basically said HFNO patients did well with reducing the mortality, but this study did not show that. I think that's what they wanted to look at. And the ICU mortality and length of stay, there was no difference between these 2 groups. So this was the third meta-analysis. And then there was a network analysis that came by the Canadian group in 2020. Even here, they showed HFNC reduced the intubation rate. And as you see, the confidence intervals were significant. And this is the forest plot, which shows the significance. So all in all, so these were 5 studies which I showed you. So one is a randomized control, which paved the pathway to all this meta-analysis. So 4 meta-analysis and the 3 meta-analysis, 2 from Canada and 1 from China, which clearly showed that in hypoxemic respiratory failure, HFNO does have some merit in reducing the intubation rate and improving the comfort level of the patients as well, and improving the dyspnea. Even the negative study, the US study showed it improved the comfort levels and the dyspnea. So this is the body of evidence we have at this point of time for hypoxemic respiratory failure. So we'll move into the immunocompromised patients, because this is also a very important group of patients who come to ICU with respiratory failure, and we need to understand as to how these patients need to be managed with oxygen delivery devices. So this was a good study which came from the French group. So for all the listeners, I think French have done the maximum, seem to have done a lot of studies in HFNO. So this came from the 9-1 study group by Azoli group from the French. It was a prospective study of 1,611 patients. So HFNC in this particular study reduced the intubation rates. And then there were 2 post hoc analyses again came from the French group. The REVA network is the one which did the Florale study. And there was another study which came in 2017. Here they did not show any difference with the intubation rates. But there was one randomized controlled trial, which is called the high randomized controlled trial, which predominantly looked at immunocompromised patients. So they took at 778 patients and they compared HFNC and the conventional oxygen. And they found that PaO2 by FiO2 ratio significantly improved with the use of HFNO, and tachypnea also significantly improved with the use of HFNO. But all these other indicators, the endpoint indicators like mortality, intubation rate, length of stay, dyspnea, comfort, there was no difference between the HFNC and conventional oxygen therapy. So immunocompromised, so we have one French study, which is a prospective one, which showed reduction in intubation rates. Others did not show difference with regards to reducing intubation rate. But as you see, the high randomized controlled trial, one of the positive things is it did improve PaO2 FiO2 and it did reduce the tachypnea as well. So this is the body of evidence we have for immunocompromised patients. Then let's look into post-extubation respiratory failure. So we have 2 randomized controlled trials. So this was a trial which came from the Spanish group. It came in JAMA 2016, which is a positive study. 527 patients randomized to HFNO and conventional, and they found the intubation rate was significantly less in HFNC as compared to conventional oxygen therapy, in especially post-extubation respiratory failure. And respiratory failure also was less when HFNO was used in comparison with COT. But the limitation of this study was the blinding in this particular study was imperfect, and there was a significant bias because they took predominantly post-surgical cardiothoracic sort of patients in this study, which was possibly a potential bias. Then there was this trial called OPERA trial, which came from the French group in 2016, again to look at post-extubation benefit of using HFNO. So they took mainly post-abdominal surgery in these patients, because abdominal surgery, they would have some splinting of the diaphragm and atelectasis and so on and so forth. 220 patients compared between HFNC and COT. Again, there was no difference with the respiratory failure between these 2 groups. So these are the important sort of trials that came in post-extubation respiratory failure. So now we look into post-surgical respiratory failure, because there were 9 meta-analyses. There were 9 randomized controlled trials and 2 meta-analyses. So this particular study came from the Chinese group in 2018. It was a meta-analysis of 7 trials, 2,781 patients, where reintubation rates, as you see, was no difference with HFNO because confidence interval was not significant. But in the patients where reintubation rate they looked at, they took a subgroup of patients who were critically ill. So they took a subgroup analysis and only looked at critically ill patients. There it did show reduction in the intubation rates and it attained statistical significance. And so in post-surgical respiratory failure who became critically ill, possibly the use of HFNO helped in reducing the intubation rate is what they subscribed to in this particular study. Then this was this Canadian study which we spoke in hypoxic respiratory failure. They did the subgroup analysis predominantly in the post-surgical patients. where they showed intubation rate was significantly reduced with the use of HFNO. As you see, confidence interval is significant, and the need for escalation of respiratory support also was significantly reduced in this Canadian study. So it attained statistical significance. So all in all, so I covered the 4 groups of patients in hypoxic respiratory failure. We had 3 meta-analyses and our Florale trial, which substantiates that it did show reduction in the intubation rate. In immunocompromised patients, we saw one prospective study which showed a good substantiation that it reduced the intubation rate. And post-extubation, we saw 1 positive and 1 negative. And then in post-surgical, we have these 2 sort of a meta-analysis which seem to give a signal about its benefit in reducing the intubation rate. So this is the body of evidence, and these are the typical patients we see. So the take-home message that we can draw is there seems to be a good scientific plausibility for HFNO use, even from the technical standpoint and the physiological standpoint. It makes sense. It gives good humidification. It gives a very high flow oxygen, and there is a good comfort level. It does have good mucociliary clearance, and it reduces rebreathing. It improves alveolar ventilation. It reduces the dead space. So all these physiological aspects, it does have a good scientific plausibility that yes, HFNO possibly has a place in our ICU and is a very good adjunct. And I use the word, it is a very useful adjunct as a high flow oxygen delivery device in ICU. It is an adjunct, which means I wouldn't say you use this, patients will all survive and they will get better. So it is an adjunct like any other respiratory device. If patient needs it, we use it, and it helps him to tide over the crisis, well and good. So that is where its role is. And there seems to be a good body of evidence, as we discussed, in hypoxic respiratory failure, immunocompromised, post-extubation, and post-surgical respiratory failure. But an important message to all the listeners is, it is not a substitute. So don't look at it as a substitute for NIV. Don't tell that this will replace NIV. So this has its own space, this has its own role, and we saw that in COVID, we saw that in interstitial lung disease, we see it in many groups of, we see it in palliative group of patients. And it is not a substitute for intubation thresholds. So your intubation thresholds are determined by the clinical context and the patient's response to the oxygen delivery devices, and the patient's trends in the improvement is what should determine. So that is a very important statement I wish to make. So it is a good adjunct, good place in ICU, reasonable body of evidence, but don't look at it as a substitute for not intubating or not putting, using NIV if they are failing on this for any other reason. And most importantly, look at the patient, look at the clinical trends, and look at the clinical progression, and look at the clinical context to determine its usage. So thank you everyone. So I end with this beautiful quote. So better keep yourself clean and bright. So we are the window through which you must see the world.